Hello, I am Dr. Janice Williams, and this lecture will be covering gastrointestinal and abdominal conditions that a patient may present in a primary care practice with. These slides have been adapted from F.A. Davis Company. This lecture will focus on the perspective of evaluating, assessing, treating, managing, and prevention from the primary care perspective. Some common complaints that your patients may present with related to gastrointestinal or abdominal concerns are complaints such as abdominal pain, constipation, when they talk about having a difficulty or infrequent defecation, diarrhea, where they're having increased frequency in their stools, and dyspepsia or heartburn. When you think about any diet complaint that your patient presents with, as a primary care clinician, one of the first things you may want to consider and try to evaluate, is this an acute complaint or is this a chronic complaint? Acute, lasting less than a week to 2 weeks, whereas chronic is more than 2 weeks. These complaints do not stop with just the abdominal pain, the constipation, diarrhea, dyspepsia, or heartburn. It also includes things such as jaundice, melanoma, black tarry stools, patients complaining of nausea and vomiting, and difficulty swallowing. And then as a primary care clinician, you're trying to establish what may be the cause for these complaints. And then is there a treatment and what treatment will be best to help address your patient's complaint? Let's start talking about gastroenteritis, which is talking about an inflammation of the stomach or the intestines. As a primary care provider, as I mentioned earlier, want to establish, is this acute or chronic? This you can establish an understanding from by getting a comprehensive HPI. As you all may remember, that's that utilization of the acronym OLD CARTS. Onset, location, duration, character, aggravating, alleviating symptoms, relieving symptoms, and treatments or modalities that have been used. That can help you come across, is this acute or chronic? And then you're going to talk about what may be some of those managements that may be needed, right? But before you can talk management, it's important to identify when they come in with gastritis, is this a bacteria or viral, right? A lot of this is going to be based off of the information you retrieve from your patient and then doing the appropriate evaluation with your labs and diagnostics to determine the difference between bacterial and viral. Educating your patients when they present with gastritis that oftentimes gastritis is a self-limiting condition, which means that it impacts your patient and your patient alone. And so therefore, treating the symptom that they present with is going to be a big part in managing these patients. However, understanding that when patients present with gastritis, there can be many contributing factors. So trying to understand, is there anything in your patient's history that is contributing to the symptoms that they're presenting with? So on top of doing your history of present illness, you want to understand the patient's medical background. What medications are they on? What things have they been doing lately? What things may they have been exposed to that may be contributing to those symptoms? As mentioned, where you're trying to understand what may be going on with your patient, knowing that depending on the causative factor will determine what the treatment should be. As you see from this slide, if the cause for the gastritis is related to a patient traveling and they are exposed to a specific bacteria, depending on what the bacteria is determines what the treatment may be. But understanding what bacteria, what infections are found in what areas will help you when you're collecting that history and taking a thorough evaluation and physical exam on your patient. What does the history tell you? Have they been traveling? Do they work in an area where they're exposed to different bacteria or viruses? Has anyone else in the family been sick, right? These are all going to be important questions that you want to ask your patient. And then once you've asked your patient and you then start to determine what may be some of the offending agent or bacteria or viruses more specifically that may be leading to these symptoms, run in the appropriate diagnostic test. And the diagnostic test can be multifaceted. So looking at your basic CBC with diff, your SED rates, your CMPs, your urine cultures are important, but also maybe running stool cultures. Taking stool samples will also help you. So now let's move on and talk about constipation. Constipation is defined as a decrease in the frequency of bowel movements of fewer than 3 bowel movements per week. Understanding the definition of constipation is going to be needed when having a conversation with your patients about constipation. What a patient defines as constipation can differ than what we define as constipation. Getting an understanding of what your patient's normal routine is in relationship to their bowel habits is important. But not only understanding the routine of their bowel habits, how frequently, but being able to speak with them in reference to the type of bowel movements that they have. Here you can see the Bristol stool chart. This will help you to have a conversation with your patient related to their stools and their bowel movement, explaining to them or showing them what the different stools look like so it helps you to understand how you want to classify their constipation. And when it comes to diagnostics, when you're looking at constipation, you want to think about if you need to do a diagnostic. That diagnostic should not be performed or ordered just because you don't know what else to do. When you perform a diagnostic on a patient, it should be based off of your medical or your knowledge. It should be based off of you understanding what the imaging that you are about to order can identify or cannot identify so that you choose appropriately. And lab work should be drawn accordingly. Understanding when patients present with GI complaints, a lab that I think often gets overlooked is a urine analysis. Individuals often forget that things as simple as a UTI or can contribute to GI complaints. But you do want to include that within your diagnostics as you're evaluating these patients, on top of looking at your CBCs, your chemistry profiles, and maybe even looking at your thyroid studies, because what we know about the thyroid is hyperthyroidism can possibly lead to diarrhea, whereas hypothyroidism may be a contributing factor to constipation. So let's talk a little bit about and go through this case study here on a patient with constipation. You have a 58-year-old woman with a complicated history of chronic low back pain, bipolar disorder, mixed anxiety, depressive disorder, who presents to you, her primary care, complaining of constipation for several months. Constipation has been intermittent and has gotten worse over the past few weeks. She is now having a bowel movement about every 4 days. Her stools are hard and painful, and she has bright red blood in the toilet paper after she wipes. She does not feel she is able to completely evacuate her bowels. She denies melanoma, abdominal pain, bloating, excessive gas, loose stools, or fecal incontinence. She's afraid to take medications and has not tried any over-the-counter treatments for fear of the side effects. She has had no changes in her regular medications and no short-acting narcotics for breakthrough pain. She reports a regular diet. So she's doing her lean proteins, her fruits, her vegetables, and her grains, and without changes. She admits to not drinking enough water. She's taking in about 20 ounces daily. She denies consuming caffeine or alcohol. Her stress level has not increased. She admits to daily anxiety that limits her activities and reports anxiety at a baseline. She has never had a colonoscopy due to her anxiety about the procedure and the potential outcomes. Her chronic low back pain has been stable for the past 6 years with current medications. She has been on the same dose of extended release morphine for 4 years. Her fears discontinuing morphine will result in worsened back pain. She does not exercise. She does not go to physical therapy and is not followed by pain management. When you look at her review of systems, it's positive for constipation, bright red blood in her rectum, and her anxiety. Her review of systems are negative for fever, night sweats, weight change, fatigue, hair or skin changes, heat, cold intolerance or belching, halitosis, heartburn, early safety, nausea, or vomiting. The patient was also negative for chest pain, her palpitations, no shortness of breath, no mania, no ideas of grandiosity, no hallucinations, suicidal ideations, or worsening of her anxiety or panic attacks. Now, what is pertinent about her history? Her medical history is significant for asthma, and as a child, she has bipolar, mixed anxiety and depressive disorder. She has GERD, hyperlipidemia, hypothyroidism, second to her lithium use. She has IBS, constipation, chronic low back pain, psoriasis, diverticulitis, primary hyperparathyroidism, hypercalcemia. She had a partial resection 15 months ago. Her social history includes no alcohol, no tobacco, no recreational drug use. She is married with no kids. She volunteers at her church, sings in the choir, and does charity work with older people. Her family history doesn't really contribute anything. She's not allergic. She is allergic to penicillin, but no food allergies. She is on levothyroxine, omeprazole, morphine, lithium, clonazepam, desanide, and albuterol inhaler as needed. You can see here her vitals and what her physical exam findings are, right? They're normal. Her abdomen, I would like to point out, is soft, non-tender. It is not distended. She has active bowel sounds in all quadrants, no hepatosplenomegaly or masses. I want you to take a minute to think and provide 3 differentials that you see from this case study, right? And what is the most likely diagnosis and why? What from her history, what from the physical exam do you glean would be the most likely diagnosis? Demonstrate your understanding of the pathophysiology. I want you to think about what is the pathophysiology that occurs that you know of. Even consider your pharmacology. What things about the medications this patient is on may contribute or prevent what may be happening here, if at all. Think about what test or imaging you would order, which one and why. At this time, I want you to also remember you can pull out, you have an advanced health assessment, clinical diagnosis and primary care textbook or referral reference guide that was recommended. You can utilize those resources to think about what would you order for this patient, what labs and why, understanding that. And what would be your next appropriate steps for this patient? What are some of your treatment options that you can provide for this patient? And if you had to do an ICD-10 code and CPT code, what diagnosis would you give? What CPT codes would you recommend? And with this patient, the appropriate patient education that should be provided for her. And then I want you to think about what are the medical and legal concerns that you need to consider? And do you think you need to consider interprofessional collaboration with anyone on this patient case? I'll give you a few minutes to do that, and then I'll come back and we'll talk about it. I would be amiss if I would not also include in this case study for you some questions related to bedside manner, which is very important for us as clinicians. What would you communicate, or what style or approach would you use with this patient? And if your patient is distressed by the diagnosis, what type of support could you offer to this patient? And I want you to think about this patient's history with anxiety and everything else, and how your patient did verbalize to you that she was unable to do a colonoscopy because of her concern already and anxiety about what the procedure may um, report, right? So now I want you to take time and you can read over the answers to each one of those questions here at your leisure. Take the time and really look at these answers and see if this is what you came up with in reference to the case study. And the reason this becomes important is being able to apply in the clinical setting what you have learned in didactic is important. And case studies allow you time to synthesize, analyze, and then be able to apply that information in, um, in a way that just reading the content or memorizing the content cannot do. Okay? So that is your case study and your answers that you can look through and spend time on. I would like to take a minute to stay on your answers to question 7. And this is related to your ICD-10 codes. Start to begin to understand that your ICD-10 code, as you list them on your patient's records, should reflect the way you performed your assessment and your documentation. So the history of present illness should align with your first diagnosis on your assessment plan for your ICD-10. And then the other ICD-10 code should follow in a scaffolded, layered manner. So if the first reason you saw the patient was for constipation, that would be your first. If you had to address her bipolar, her hypothyroidism, her back pain, her anxiety, you would list them according to how you address those. But your primary should be the first diagnosis that addressed the patient's complaint. Okay? And then remember to include your patient education. And always remember, as a primary care provider in advanced practice, we cannot care for patients by ourselves. We care for them in a team. So now let's transition to hepatitis. I'm not going to go into a lot of detail here on hepatitis, as we've had another lecture that I spent time on discussing the diverse types of hepatitis. Remember from that lecture, we talked not only about viral hepatitis, which has 5 that we introduced you to, hepatitis A, B, C, D, and E, but we also talked about some of the other causative types of hepatitis, like autoimmune hepatitis, alcohol-induced hepatitis, steatohepatic hepatitis, those other types of hepatitis that still causes the inflammation, the damage, ultimately fibrosis and cirrhosis of the liver. We talked about how do you manage a patient who presents with hepatitis A, B, C, or even some of the cirrhosis of the liver that can be a result of either of those outside of hepatitis A that does not normally lead to cirrhosis. But we did already speak to those things and what were the causes for it, right? So you can take time to look through these slides to kind of see if you can refresh your memory, to see if you understood the content that was discussed in the previous lecture related to hepatitis, understanding the impact of hepatitis on other systems in the body, such as the blood pressure and some of the other complaints that your patients may present with, right? So when you also think about performing evaluations on your patients who have GI complaints, is understanding the diagnostics. Diagnostics, it would include things like the CBC, the C-reactive protein, and the urinalysis, ultrasounds, CTs, MRIs, and even checking their stool, right? And getting stool samples. There are treatments that do exist for our patients who present with GI complaints. These treatments can be general interventions, or what I would like to refer to as treating the symptoms your patient presents with. And then we also have those that may be pharmaceutical. Does this patient need antibiotics? Is there a infection that is bacterial that is requiring medication management with an antibiotic? Or is it fungal infection? And knowing the difference between a bacterial and a viral infection, right? Now let's move and talk a little bit about appendicitis. That is inflammation of the appendix, right? Usually caused by either obstruction or infection. You can have where the inflammation gets so severe that there's also obstruction. And when you have that, you think of referring those patients out to specialists for consideration for an appendectomy. Your responsibility as a primary care may be to do a pre-op clearance on your patient, approving that your patient can go through this surgery without a problem. However, if the appendectomy has to happen immediately, that's something they will do at the facility that may be doing that appendectomy. Another common complaint that your patients may present with is a disorder such as gastric reflux disease or peptic ulcer. Gastroesophageal reflux disease is when the stomach or the duodenal contents backflow into the esophagus. This can be a long-term condition, and it can be a result of not only their dietary habits, but also structures. Important information to tell patients who present with these symptoms is, one, having a discussion about healthy dietary habits, what foods they can or should eat and which ones they should avoid, and what is the complication that can occur when the patients consume foods that they may want to consider avoiding, such as patients who have gastric esophageal reflux disease may see a worsening of symptoms after drinking coffee, eating foods with caffeine, spicy foods, well-seasoned foods, tomato-based products, foods. So having that discussion with your patient. Also encouraging your patients not to eat and then lie down. They should sit up in a chair for at least 30 minutes to an hour after eating. This would allow food to digest because sometimes the muscle, the sphincter muscle can relax, and it also just contributes to that reflux of that those contents. Peptic ulcer disease, this is when you get a penetration of the muscularis mucosa. It's usually larger than 5 millimeters in diameter, and you can manage that with pain relief. You need the ulcer to heal, and you want to try to prevent complications. Utilizing things like H2 blockers can help with that. Patients may present with the complaint of hemorrhoids. Hemorrhoids can be internal or external. The management for hemorrhoids is oral analgesias if they have pain. They can do sitz baths, increasing their fiber, and sometimes they may need surgical intervention. You can use also rectal suppositories such as Anusol to help shrink hemorrhoids and give some relief. They also have wipes, so this way patients can get some relief when they do have to have a bowel movement. Also encouraging patients not to strain when they're having a bowel movement, and encouraging them to make sure that they are consuming enough water, which will, the benefit of that is reducing constipation, which will contribute straining if they're constipated. Abdominal hernias is when you have a protrusion of the peritoneal line sac. It comes through, it causes a defect or weakened area in the abdominal wall. If that occurs, there's a difference between abdominal hernias that are retractable and irretractable. They are just what they sound. Retractable is when you push on it, it is able to retreat back into the abdomen. Irretractable means it stays pushed out, which can then lead to strangulation, which can be a medical emergency. So having those patients evaluated by a GI specialist to see if they need to have surgery or not. But until then, also having the discussion with not straining when they have a bowel movement, good body mechanics, in the concern of lifting heavy objects that can worsen hernias. We'll now transition to irritable bowel syndrome, which is when the functional GI disorder characterized by abdominal pain or discomfort. We know that men are affected by IBS, is what we refer to it often as, 2 times more than men. The symptoms usually have a pattern, and then we do want to let these patients know to avoid certain foods that may exacerbate the condition. Inquiring with patients about their stress levels also is something I've learned that can be helpful for these patients. Oftentimes, women can carry their emotions in their GI system. So if they are highly stressed and things of that nature, their irritable bowel syndrome can be exacerbated. Now, irritable bowel syndrome can either be irritable bowel syndrome with constipation or irritable bowel syndrome when they have diarrhea. The treatment will look different. If they have constipation, then you want to give them treatment modalities to reduce constipation. If they're having diarrhea, then you want to talk to them about treatment modalities, both pharmacological and habits that can reduce that. There is also a GI disorder known as celiac disease. This is when patients have a sensitivity to gluten. And one of the things you want these patients to do is avoid gluten. So these are where we come in with these gluten-free products. There is things within the GI tract or disorders known as bowel obstruction. This isn't a medical emergency. These patients need to be sent to the emergency room for evaluation. They have obstruction. They can be partially obstructed or they can have a full obstruction. And depending on if it's partial or full determines the treatment. Partial obstructions can sometimes be medically managed to get relief. Full obstructions may require surgical intervention. Diverticular disease, which is inflammatory changes that occur within the diverticular mucosa of the intestine, as well as asymptomatic uninflamed outpouchings called diverticulosis. Education, education, education becomes an important part of this. It is talking to those patients about how do you reduce that risk, right? So make sure you educate those patients. Another gastrointestinal disorder is inflammatory bowel disease. This could be chronic immunological diseases. It happens in the intestinal tract. That's ulcerative colitis and Crohn's disease. These patients are patients that will be followed by GI. You will definitely be referring them to GI for evaluation, management, and treatment. And then you will just be doing your continued collaboration with those specialists related to these disorders. We also have colorectal cancer. It's the second most common cause of cancer death. One thing about colorectal cancer, it's important to get a good family history on every patient for this reason, because family history is a risk factor. Diets that are high in fat, red meat, refined carbohydrates, and low plant fiber. So think about when you're collecting your patient's dietary history, why it's important to ask the specific questions. Don't just glean on, do you have a healthy diet? And don't let your patient just say, yeah, I'm consuming, yeah, I eat well. You need to know the specifics. You then also need to combine that with what their family history is. You may have patients who don't really know their family history. So when you have patients who have risk factors, such as the fatty diet, the consumption of refined carbohydrates, the low plant fibers, you need to be looking at what are the guidelines for evaluating patients with disorders like this, i.e. FIT tests, colonoscopies, tests that can evaluate for cancers. At what age should you start that with that patient? The prevention and the preventative measures is very important, especially for those patients who are at high risk factors. Cholecystitis, this is when you have acute inflammation of the gallbladder. And then cholelithiasis is a result of the cholesterol stones, right? You want to make sure that you're doing the appropriate diagnostic tests to evaluate for that, and then managing them with their low-fat diets. And then if they have kidney stones, you want to send them for evaluation for removal of those stones. We call the procedure most times a lithotripsy, where they can go in and use shock waves to break up those stones. We also have disorders of the gallbladder and pancreas. Acute pancreatitis, inflammation of the pancreas and surrounding tissue. They can be, the symptoms can be mild and they can improve within 48 to 72 hours. Severe symptoms, however, can cause complications in other organs. So, and also be life-threatening. So if you are considering acute pancreatitis as a diagnosis, this patient needs to be evaluated in an emergency room or by a specialist and get management accordingly. This is not something that you will wait on and um, sit on waiting for your labs and stuff to come back if you think it's acute pancreatitis. However, you do also have chronic pancreatitis, which is a progressive inflammatory process. Usually we see this with or can see this, not usually, we can see this with our individuals who consume a large amount of alcohol. And we say I think they said about 70, 80% of the cases are related to that. So what do you see with these patients? That they can have a hypersecretion of protein without the increase in the ductal bicarbonate secretion. And then they have inflammation. So when you look at their labs, it will be indicative of pancreatitis. I recommend again that you go back to your lab reference book and look at pancreatitis and what labs should be ran and what the results would look like if a patient has pancreatitis. More severe issue with the pancreas is also pancreatic cancer. It's a very common neoplasm of the pancreas. There are risk factors for patients who may get pancreatic cancer. Family history is again here, alcohol use as we age, tobacco use, and obesity. This is a treatment intervention that will occur by the specialist. Your patient presents with abdominal pain. You utilize your ability to do a effective or thorough assessment of your patient, collect the labs, and if you are concerned of any type of any type of cancers, or you think anything is an acute illness, you refer them to the emergency room for evaluation and you follow up with those patients accordingly. And again, we just want to briefly mention the cirrhosis of the liver. As we talked about in our previous lecture, it is very common for patients with cirrhosis of the liver, or it can occur that people who have cirrhosis of the liver can then transition to hepatocellular carcinoma. So if you have a patient who has cirrhosis, doing evaluations of their liver, i.e. with ultrasounds or CT scans, is important on a routine basis. So if your patient is not being followed by a hepatologist, knowing that you should be referring those patients who have cirrhosis to the liver to a hepatologist, and also ensuring as the primary care that they are getting their routine every 6 months or so diagnostic tests to continue to monitor their liver, as well as an EGD to evaluate for esophageal varices. That can also be very common in our patients with cirrhosis of the liver. And when they have, or if they have esophageal varices, these are patients that you would want to put on a beta blocker. These patients to reduce their bleeding of those varices, as well as if they have cirrhosis of the liver, they may retain fluid in their abdomen called ascites. These patients may be patients you see are on medications like spirolactone or furosemide. These patients do get their diagnostic tests. Their liver function test should be ran, as well as their CMP, CBCs, and you as the primary care should be evaluating their other organs to make sure that they are doing okay, and reviewing the consult note from their specialist to see what complications or how they are treating that patient, so you can make sure that you're aligning with their treatment of care and helping to support that specialist who may be treating your patient for that specific disease process. Management for any patient, but especially our patients with cirrhosis of the liver, is abstinence from alcohol, being mindful of if they need dietary supplements or which ones to avoid, i.e. iron. As you may remember for your pathophysiology, the liver and its impact on the production of iron, and you do not want these patients to have an increased store of iron, right? And then you treat those symptoms accordingly.